So welcome everyone to our webinar today on reducing risk and increasing support, future directions in dementia care. I'm so pleased today to be joined by my colleagues, Laura Tamblin-Watts and Kathy Barrick. They're going to share their expertise in this area and their knowledge and the recent reports that they've both been involved with in writing, looking at examination of dementia care. Not only what's happening currently, but what we need to do in the future in terms of recommendations. So we're so pleased to take your time. I know you're very busy people, so we do appreciate you doing that. Just as a reminder that we are funded through the Ontario government, but the opinions and information expressed today are not necessarily those of the government, but of our speakers themselves. Before we begin, I do want to give our land acknowledgement. We acknowledge that we gather on the traditional territory of a number of First Nations and acknowledge their stewardship of this land throughout the ages. We seek a new relationship with the original peoples of this land, one that is based in honor and deep respect. Thank you. A few housekeeping items as usual. As everybody knows, you will be muted during the presentation today. We have over 100 people that were registered for the session today. So just a reminder, we do have this as a recording, so you can get the PowerPoint and the recording after the session. Our speakers will be visible during the time that they're speaking, as well as our ASL interpreters on the screen. If you would like to make the screen larger for the interpreters, you can shift the bar between the presentation and the speakers to make it larger, or you can pin them yourself. You have controls at the top about how you want to see the visual. If you just want to see the speaker alone, that is up to you to do that, whatever works best for you. Just as a reminder, as I mentioned, you can put comments in the chat box. We always welcome people commenting through the presentation. You might know of some new resource or want to share a comment on what somebody's been saying. If you have a specific question for our speakers, please post it in the Q&A box so we don't miss your question that you would like to ask. And we'll take those up at the end of the session today, where we'll have a really nice engagement with both of our speakers on this important topic. As I mentioned, we are recording the session. It will be posted after the webinar for people to access. And at the end, we will be reminding people to provide a evaluation. We have kind of modified the evaluation to be shorter, so it's quicker for people to respond and giving people the opportunity. There will be a link sent out, but also if you have your phone handy, you can also scan the QR code, which takes you directly to the survey that you can fill it out right away. That QR code will be posted at the end of the session as well. And just lastly, before I introduce our speakers, just a reminder that this is a public forum. If you have any personal situations or issues that you want to address offline, please reach out to us. We're more than happy to speak with you about a situation or circumstance. If you have general questions that you'd like to post, please do so. We're more than happy to talk about that with you. Just a reminder that, giving personal identifiers in terms of maybe a family dynamic or something, we can assist that further offline to make sure that you get the support that you need. For those who are joining us for the first time, just to give you a couple slides just about who we are. Elder Abuse Prevention Ontario is a nonprofit organization. We envision a province where we see all seniors free from abuse, feel safe and respected within our communities. And the work that we do is trying to reach that mission to raise awareness, provide education and training, and work with our community partners. And in 2003, our organization was given the mandate by the Ontario government and currently under the Ministry for Seniors and Accessibility to implement the Ontario strategy to combat elder abuse. And we've been doing so ever since. Now, that strategy has three main priorities, which is public education awareness, training for frontline staff, and that coordination of services. under each of those pillars, there are many activities and initiatives that are done and expanded over the years since we began to address the issues of abuse. So our training has gone really broader than when we first started, reaching many even businesses and corporate sectors now, as well as nonprofit volunteers and senior organizations. You name it, we're kind of out there trying to reach out to all different sectors to inform them about how they can recognize abuse and support older adults if they do come across someone that's at risk. So now I get the opportunity to introduce my colleagues and our speakers today. I'd first like to introduce Laura Tamblin-Watts. She's the CEO of CanAge, which is a fairly newer organization that Laura has formed and is the founder of, which is Canada's national seniors advocacy organization. If you haven't seen Laura in the media, she's on TV and newspapers and interviewed in many facets in the work that she's doing to advocate for seniors' rights across this country. She's very passionate about the work that she does. She's got a lot of work and experience in long-term care and home care, financial security, elder abuse, obviously, healthcare, ageism, and she's worked with many marginalized communities. Prior to CanAge, she also worked with the Canadian Association of Retired Persons, and she's got 20 years of experience working as as a lawyer. That's her background as well, defending the rights of older persons. So we're so pleased that you're able to join us. Should mention also that Laura is also on our board of Elder Abuse Prevention Ontario. And with us also is Kathy Barrick, who's also a colleague with the Alzheimer Society of Ontario. She's the CEO, and she has worked in this field for also many years within the nonprofit sector. And Kathy's drive comes through the innovation through fundraising and program development. And she also believes that nonprofits should step up and shine by increasing their social profit margins. She's worked in the nonprofit sector, as I said, for over 20 years. And she also has a recent entrepreneur fellowship graduate from the School of Social Entrepreneurs. I've worked with Kathy in many capacities with elder abuse as well, and with the Alzheimer Society, as well as colleagues across Ontario and the different elder abuse. I keep saying elder abuse. Alzheimer societies. I apologize, Kathy. So we are so pleased that she's able to join with us to share her knowledge in this area. Because they've been involved in both speakers in developing these new reports that we're going to hear about today. So the Alzheimer Society of Ontario, Kathy's been very involved in the report around the roadmap towards a renewed Ontario Dementia Strategy, and also involved in the Canadian report on navigating a path for dementia care. And alongside with that, the CanAge developed the recent Dementiain Canada Cross-Country Report that was released. All these reports have been released just this past year, and many just in the past months. So we're hoping that we have a really fruitful discussion today, just talking about what are our prevalence and projections of dementia, why we need to be paying attention to this, how we can reduce the discrimination, ageism, and stereotypes, and the challenges that come with that. And what most importantly is the impact on our healthcare system and for seniors and families working with those the healthcare sector, but also managing at home with the home care sector, and what we need to do as a collective to address these issues, because we can't do these. We can't address this alone. We have to work in partnership. And I think both our speakers will have excellent recommendations and steps that we can all take in addressing this. So I am going to turn the screen over to Kathy to give us a little bit more insight on the reports and her experience.
Thank you, Rayanne, and welcome everyone. I'm really thrilled to be here, and always love presenting alongside Rayanne and Laura. So I'm actually going to speed through a number of slides actually, and they include a lot of data, information. Fret not about sort of absorbing all the numbers that I'm going to be talking about. We really just do this to help illuminate the huge issue that dementia is today and will be into the future. My slides are fully available, as well as our reports are available online. So if you want further information or you wanted to remember a stat, all of that is available to you. So the Alzheimer Society of Ontario, as well as a number of our colleagues, present company included, got together, and this was actually around the election in the spring in Ontario. And we wanted to put together a report, which is the roadmap towards a renewed Ontario Dementia Strategy, really as a gift to the government and all candidates to say, listen, we need a renewed Ontario Dementia Strategy, and this is what we think will make a difference. So we wanted to have all the information for them at their fingertips so that once elected, they could just enact the number of recommendations that we've made. Additionally, the Alzheimer Society also just released a landmark study, and it is the first of 3 reports that actually look at dementia in Canada. So I'm going to be going over some of the statistics and information derived from both of these reports. So the number of people living with dementia in Canada already is profound. In Canada today, or 2020, almost 600,000 people are living with dementia. I want to note, however, that that number, we believe, is likely underreported since many people don't get a confirmatory diagnosis. But of the ones we can count, about 600,000 folks in 2020 had dementia. Nearly half, 250,000, reside in Ontario. What's extremely startling is if you look over to the 2050 column, the number will explode for lots of different reasons. But the one that we hear about the most relates to our aging population. Our boomers are getting to the age where dementia becomes more prevalent since age is the biggest risk factor. Oops, clicked a little too quickly. So over the next 3 decades, we're going to see over 6.3 million new diagnoses of dementia. And when you think about that, aside from it being an extremely alarming number, what's really alarming is we can't even manage the number of folks that we have today living with dementia. And when you break down those numbers, by 2035, which always seems like such a long time away, but it's not, we're already almost in 2023, about 8,300 new cases will be diagnosed a month. That's 275 people a day, and 11 people every hour will be diagnosed with dementia. So I think there's little doubt that we can all agree that dementia is a growing and perhaps the #1 health concern coming up. The provincial breakdown of cases, as you can see, Ontario is by far the highest. Not surprising since we are the most populated province in the country, but it is obviously a huge problem across the country. Even the smaller numbers, PEI, it's a pretty small place, but their infrastructure matches their smallness. So even, a relatively representative number within PEI is still a significant number. This is the age breakdown projected both actual in 2020 and then projected to 2050. And here you can see this slide really shows the increasing numbers by age category, but you can also see here that age is the biggest risk factor for people developing dementia. It is not the only one, but we do know that as people age, their risk does increase. So support for people living with dementia. This is near and dear to my heart, as it is to Laura and Rayanne. Most people living with dementia actually reside at home. And that's where they want to be. And so a lot of the work that we do at the Alzheimer Society is really try to equip policymakers with information about what policy changes can be made and funding changes that ensure that people who want to live at home can remain there. As well, we cannot talk about dementia without including a very strong focus on care partners. These are the informal caregivers. These are not the professional caregivers like nurses and PSWs, et cetera, but these are family, friends, colleagues, whoever it is in the person living with dementia's life that is providing support for people. And of course, for every single person that's living with dementia, there's at least one care partner, if not 2, 3, 4. It takes a village. The old saying, it takes a village. It really does take a village to support people living with dementia. We cannot forget those people. So here's some care partner estimates. And without going into detail about the numbers are there for you to see. But if you look at the bottom, in 2020, unpaid caregiving. So these, again, are family, friends, colleagues, acquaintances, whoever, people from your church. It's equivalent, the number of hours that were provided to people living with dementia is equivalent to over 100,000 full-time jobs. So if dementia were the province, was an employer, it would be one of the province's largest employers. When you look at 2050, so less than 30 years from now, over 320,000 full-time jobs of people caring for people with dementia who are not being paid to do so, but doing so, in their, I say in quotes, spare time. Care partner distribution, age distribution. The age distribution of care partners is actually younger, as you would probably imagine. And you see sort of the middle grouping here. These are people in my age of life where my parents are older. So should my parents have dementia, I would likely be one of the primary care partners in their life. And the interesting thing about that middle age group as well is we've called them the sandwich generation for many years, because people in those age groups are often looking after aging parents as well as children as they're launching off into their teenage or, early 20 years. So it's really important to consider, and, we haven't maybe done the greatest job of this as, other diseases, is talking about prevention. And aside from it being a really good thing to do because you don't want to get dementia, so doing things that can help you prevent dementia will improve your own quality of life, it actually has a very significant impact on the system. And so the landmark study that was just done looked at some modeling to say, well, what would happen if we were able to delay the onset of dementia by a year, or maybe even 5 years, or maybe even 10 years? What would that do to the numbers? So you can see in the top right here on this slide, if we were able to delay, and I'll just talk about Alzheimer's here, if we were able to delay the onset of dementia or Alzheimer's by 1 year, that'd be 236,000 fewer cases. If you do it by 5 years, it's over 1 million. If you do it by 10, it's over 2 million people. So again, this really speaks to the need for really investigating and learning more about how we can prevent dementia, as well as, and many of you on the call may have heard the news in the last few days about a new drug that's coming hopefully soon to Canada. Drugs like that may also be a key factor in this delaying of the onset of disease, which could have a very significant impact not only on the people living with dementia, but on the healthcare system as a whole. So again, just looking at Ontario specific data here, this is just looking at those numbers that I just talked about in a different way. So, and specific to Ontario. So look at how many, what the impact of delaying that onset of dementia could do, both, as I said, for people and for the healthcare system, be profound. These are the number of people that could avoid getting dementia if we were able to delay the onset, as I've talked about. So look at the deferred by 10 years, again, huge numbers of people. So imagine if we could all be coordinated around our need for prevention and disease-modifying therapies, we could reduce the number of folks facing dementia by millions, literally. The landmark study, which I talked about, actually also looked at modifiable risk factors. So these are things, so we have genetics, obviously, and we can't change our genetics. And there are some genetic risk factors for dementia. there's only one kind of dementia that really means like you're going to, or one genetic factor that means you will get it. That is an extremely rare form of dementia. Most other dementias actually have significant numbers of modifiable risk factors, which means that if we adjust our way of living, that we may be able to delay or prevent the onset of Alzheimer's disease, vascular dementia, etc. So these, again, are just, well, there's several here, but many of the things that we can do, physical, and things that we know already, actually. Now, whether we do them or not, that may be another question, but things like smoking, physical activity, our diet, air pollution. There's been some studies that show, people who live closer to high volume highways have a higher risk of dementia. Diabetes is a risk factor, traumatic brain injury, so the number of concussions, as an example that you've had. So football players, hockey players seem to have a higher risk of dementia. Use of alcohol, weight, all of those things. So these are all very modifiable risk factors that if we were to incorporate some healthy lifestyle activities in our life, we can be working towards increasing our protective factor for getting dementia. And again, if you think about the numbers in the previous slides, if you were able to delay the onset of a disease by a year, 5, 10 years, the impact on you personally would be quite profound, as well as on the system as a whole. So these are some actions for healthier brains. And the Heart and Stroke Foundation, I think we could all probably rhyme off, what the Heart and Stroke Foundation would tell us about how to keep our heart healthy. The same goes for our brains. It's an organ, and the things that are good for our heart and for our body, generally speaking, are good for the brain. Some additional things that help as well. Social isolation has a really big impact on dementia as well. It seems to be a risk factor for dementia, and that can include things like hearing loss. So while the hearing loss doesn't necessarily cause dementia, when you can't hear, you tend to isolate from social gatherings, etc., because it's too hard to interact. So looking after your hearing, etc. Again, these are all available online and through the slides. So the government approach to healthcare, we could probably say a lot of things, but one of the things that we do say is that we really need to have a coordinated effort to support people living with dementia, and we cannot have a discussion about healthcare in Ontario without talking about dementia. The government several years ago came out with the quadruple aim, which is really how they're trying to organize the healthcare system around these 4 priorities, which is fine, but they all have to be related to dementia, and we can't be looking at solutions in any area without it including a conversation about dementia. One of the things you hear in the healthcare system as well, and in the political hallways at Queen's Park, is about hallway healthcare, and we've been hearing a lot about that lately, about hospitals not having enough capacity. Hallway healthcare is dementia. Dementia is a huge part of the hallway healthcare crisis, as well as the long-term care crisis. Dementia is also long-term care. And again, you cannot separate discussions of those 2 topics without including dementia. So again, some additional stats. So over half of the people who are in ALC beds, which are the beds, those are people who are in hospital, acute care hospitals, who don't need to be there because they're not acutely ill, but there's nowhere else for them to go. Half of them have dementia. And why does it matter as well? We did some surveying ahead of the election. A third of voters in Ontario have a parent, spouse, or someone close to them living with dementia. This is an issue that matters to people. Even, there's 67, I can see people online here right now. And every time we go and speak about this, there's always lots and lots of people. So this is an issue that matters to us right now. And the other issue that we've identified is that the wait time to get a diagnosis is significant already, and is going to increase profoundly as those numbers go up. So we've got a big problem, but we do have some solutions. So here are the solutions. So the Alzheimer Society came up with the roadmap towards a renewed Ontario Dementia Strategy. It has 77 recommendations in here, some of which are policy recommendations, but don't actually cost any money. They're just changing policies so that it's more inclusive, greater access to diagnosis, etc. As well as there's some in here that cost the government money. So 21 experts got together to, the question was, what's broken in the system? What's causing these problems for folks living with dementia in our healthcare system and in our communities, not just healthcare, and what could we do about it? And so what this group of experts came up with was 77 recommendations in 13 policy areas. Our three top asks are outlined here. So one is to develop a dementia secretariat. One of the issues with dementia is because it goes across all issues. You can't talk about transportation or housing, healthcare, etc., without including a conversation about dementia, but nobody is focused on it. So a recommendation of developing a dementia secretariat that would have the job of ensuring that all those conversations are including conversation about dementia. Integrated community-based care is critical for supporting people living with dementia. We know that the healthcare system, both acute and long-term care, cannot manage the number of people. So we have to have a really good community-based system in place that can help support people living at home, which is where they want to be. And then, of course, long-term care, looking at long-term care and what really can be done there. A huge part of that is looking at the human resources, the staff in long-term care, and ensuring that they have the adequate training to provide care. These are the 13 policy areas that the panel came up with about what is required, what categories are required to support people living with dementia. Again, this is very high level, and you can see more in the actual report. So it makes good political sense, and all of you on the call are voters. Of course, the election's over, but you all have MPPs, and what we need is for people like you to be talking to your MPPs and letting them know that dementia matters to you and that you want to see the roadmap enacted to fully support people living with dementia. That kind of says the same thing. And then that is it for my slides. I'm going to stop sharing and turn mic over to Laura.
Thank you so much, Kathy. That was an excellent overview. And I know it's hard to go through all the recommendations, but I think you hit on some really key factors and some of the stats. I know when we get to the end, there was some comments about, people with early onset. And I know that you just talked about that. And I shared in the chat box about the recent news on the new drug. So just getting people informed. And you made a really nice segue to Laura's next presentation around, reaching out to or MPP and how do we get this on the radar for politicians and changing government to have the dementia secretariat that you mentioned. So that's Laura's sort of expertise in doing that, and I think that's one of the reasons why they developed this report. So Laura, I'm going to let you share your screen and talk about the work that you've been doing, sort of looking at the landscape across Canada, but where are we at and how can you inform people to do that process of engagement with government or their local politicians to get this on the radar map?
That's the perfect entrance into this conversation because mine's called Dementiain Canada, Where We Are, What's Coming, and How to Get There. So I'm a teacher, and you'll know that I have a lesson plan associated, so you'll know exactly what we're going to talk about today. Just a quick introduction. Our organization is pan-Canadian, nonpartisan, doesn't cost anything to join. All you have to do is send an email or click the link at canage.ca/join, and that's it. Then you're a member. We have been so privileged to be working in close partnership with the Alzheimer Society of Ontario and Elder Abuse Prevention Ontario, two of my favorite organizations. We think of these issues in our roadmap, if you will, which is a framework for positive aging in Canada. And I think what's important to see is in our 6 pillar areas, or what we call them compass points, obviously dementia lives in O, optimal health and wellness. But we know that it also is one of the key risk factors for violence and abuse prevention and elder abuse in particular. We know that in disasters, people with cognitive impairment are usually the ones that have the most difficult time of all. We know that in infection prevention, and particularly during the time of COVID-19, that infection prevention and vaccination is incredibly difficult when it comes to getting people vaccinated and even trying to understand and explain why those vaccinations are important. It is central to the health and housing continuum. You can't talk about home care without talking about dementia. We can't talk about long-term care without talking about dementia or caregiving. And I would increasingly say you really can't talk about any form of housing without talking about dementia. We need to talk about the economic security of individuals, the amount of money it costs to support people with dementia is profound. And 75% of that is being done on a volunteer basis, as Kathy was saying. We need ways for people who have cognitive impairment and their supporters to not bankrupt themselves in trying to get the help and support they need. And social inclusion is at the core of it. We exclude actively and passively people with cognitive impairment. Passive exclusion is, we don't make it explainable. We don't make activities inclusive enough. We use words and not pictures. And there's a passive exclusion related to stigma and that fear, I think, of, quote, losing your mind or losing your marbles. And I use those obviously very much in quotations. So here's what I want to talk to you about today. I'm going to talk about our brand new dementia report and what we found. We're going to talk about some innovation. That's the hopeful part. And we're going to talk about how to get there and to drive advocacy, which is the practical part. And you'll have access, of course, to these slides as well. So it's kind of what, now what, and how do we get there? We originally started creating report cards in 2020. We wanted to see how we are doing in Canada with regards to adult vaccination. And when we did that, it was the first time that there was ever a cross-Canada comparison that held up adult vaccinations to a key standard, which was NACI's standards. So why am I talking about vaccination? I'm talking about it because it had a massive impact. We got about $150 million worth of earned media out of this report. It specifically changed policy. The last report in the Yukon had an F there. And I know for a fact that they actually stapled a copy of this report and sent it into finance and said, here's what we need to do. We need to fund the appropriate vaccines. We need to make the changes that are in this report. And we know that it, as a tool, has been incredibly effective in making crisply and clearly the point to policymakers and really everyone that the inequities in our system are profound and frankly intolerable. We also use this model where we pulled out specific groups or a particular spotlight in our reports. And that's important too, because we wanted to recognize that not everybody experiences health issues or social issues the same. So inspired by that, we were looking at our report cards in adult vaccination, and you see some examples here where we were able to give grades and we were able to compare findings. And we thought to ourselves, wouldn't that be wonderful if we were able to do that with dementia as well? I think it was 2019, Kathy, you and I were on a stage. I have a photo of us shaking hands with the then Minister of Finance. I pulled it out the other day to remind myself that there are real successes that happened. And the passing of the National Dementia Strategy was one of those big successes. We committed to doing that because as part of the World Health Organization, Canada said that we would implement a national dementia strategy. And the World Health Organization put out a framework for the types of things that should be included. Great, we said. We should be able to do a quick and easy review like this and be able to measure how provinces are doing against that dementia strategy and how the federal government is doing against its own strategy. No such luck. Turns out the National Dementia Strategy has no measurement framework. It's a nice set of ideas. That's okay. And then we said to ourselves, well, some other country must have done one. They must have measured it, right? I mean, this is one of the most pressing global issues on health and social care. No other country in the world had ever measured how it's doing on its strategy. So we decided to get to work. And we found some pretty shocking things. Look, I expected the report to be bad, but I didn't expect it to be this bad. Some of the things we found were profoundly stark. For instance, in 2020, there was about 6.5 million children and youth is 17 or under. So that meant that we had one pediatrician, a specialist doctor in child and youth for about every 2,822 children. It's a very specific number. That same year, of course, there were more seniors, almost 7 million seniors, and that number has gone up and the children number has gone down. So that's important to remember. We're already in that difference point. We found that we had one geriatrician for about every 21,000 seniors, almost a tenfold difference. And that number was getting more challenging. And by that, I mean, geriatricians are retiring, and we only have about 327 in the country with an average age of about 60. So there's something fundamentally wrong. Now that's geriatricians. That's not people who necessarily specialize in dementia. So what about neurologists? Well, we checked that too. Now, there's not a lot of neurologists either. And again, neurologists focus on things like stroke, Parkinson's, concussions, lots of other things. So neurologists don't specifically focus on dementia. So then we wanted to see, well, who's getting health care and from whom on the issue of dementia? So this is what the report looks like. We actually put a lot of arrows in it because we wanted to make it dementia friendly. There is text as well and videos and simple plain language that goes with this report. But you can see it's 2 pages, so it's really only 1 page at a time, but I've expanded it to show you both pages at one time. And I want to draw your attention to the bottom left-hand side where you see in yellow the number 36%. 36% of Ontario physicians say they feel comfortable, not necessarily expert, just able to recognize, diagnose, and treat a person with dementia. Yes, that's right. 64% of Ontario doctors don't feel competent to recognize dementia, to treat dementia, and of course, to diagnose dementia. Compare that, for instance, to their confidence rate in other chronic diseases. So give you a sense, only 15% said they didn't feel confident in diagnosing chronic diseases. That is really shocking. So combined with that tenfold on geriatricians, again, not all geriatricians are experts in dementia, they're expert in old people, combined with the fact that there are very few neurologists, and those neurologists aren't necessarily experts in dementia, we asked, who the heck is actually expert in dementia? Well, it's probably you joining the webinar today, and that's the sad reality. We expect that people will kind of have to diagnose themselves. In Ontario, we do have mental capacity assessors, which are private pay kind of institution, arm's length, and certified by government. But they're not medical professionals. They can help you find out whether or not a person has the ability to understand and appreciate a decision, like a healthcare decision or a financial decision, but they're not treaters. They're not people who give you a profound diagnosis. So let's look on the right side of the page. You're going to see a lot of no's there. So do we have a dementia strategy in operation in this jurisdiction currently? No. And that's pretty shocking. Ontario doesn't have one. In fact, only 3 provinces and jurisdictions, 2 of which, by the way, are territories, have a dementia strategy. I mean, that should set you back on your heels a little bit. And then please note all of the other no's. The only thing that we have is there a ministry dedicated or a shared portfolio with seniors in this province? That's it. That's the only thing that Ontario got. So is Ontario dementia ready? Profoundly no. So there's a couple of key asks, and I'm going to talk about some of the opportunities to move on these asks. Obviously, diagnosis is critically important. But we actually need information, training, and resources for the very people who are supposed to be treating us. Like if they can't recognize it, diagnosis, or care for it at the primary physician level, and there aren't really specific individual experts that you can easily call upon, we have to do better. The brain in med school gets about 6 hours, 24 minutes on consent and capacity over a 4-year period. It's pretty shocking. So these are some of the key asks we have. I hope that you see that they fall directly within the asks of Kathy's roadmap. Caregivers and care partners are key folks that are really the ones who are treating and supporting people living with dementia, really more than almost any other type of disease or illness. And I think you can all see that these are really very basic asks, but we actually don't train people on how to care for others. There's no St. John's ambulance course to take care of somebody. So we have folks, many of whom are quite high needs, and we don't have some in-person training. There's a little bits of online training, and that's good, but it's quite a bit different when you're actually trying to interact and learn. So we really need to do better. And let's not forget our healthcare workers. You know, one of the real challenges is making sure that they get appropriate training in how to interact with people with dementia. Don't come up from behind. Come in from a 45-degree angle. Don't stare. Make sure that you're reaching out in a gentle way. Make sure that it's not too fast in your speech. Make sure that it's not too difficult to understand with background noises and flashes. Let's make sure that care partners that are paid also get the resources, tools, and environments that they need as well. So what's coming? Well, this is good. Diagnosis is coming. It's good because, boy, we saw that it wasn't happening before. Our report found that on average, an Ontarian can expect to remain undiagnosed for a minimum of 7 years, 7 to 10 years. What's important about that is to the degree that there are medical treatments, they need to be caught early on. And what we know is by the time people are diagnosed, they're often not available or appropriate for the medical treatment drugs that are available. So I want to highlight to you two particular types of innovation in diagnosis that are kind of at market right now. They're not widely out, but are appropriate and finishing up their last trial. So this is pretty exciting. This is called ReadySpec. This is a Canadian company. And what you see here are biomarkers in the eye that indicate the buildup of plaques. So you can actually look into a machine like this. This is one of the machines, and somebody can see inside your eye and actually look to see, hey, you've got some of these plaque buildups. This is a real concern. This can be flagged, and it is really as painless as getting an eye exam. This is the kind of thing that you can imagine in a pharmacy in the same way that you have blood pressure machines. Now, do I think it's the same to find out that you've got high blood pressure as that you may have genetic biomarkers for dementia? No, clearly not. We would obviously need to make sure that people had the supports and opportunities for questions and so on. But the very fact that people might be able to have these types of checkups, quote unquote, in a normalized fashion may also lead, I think, to some destigmatization of it. If you can get yourself checked out very easily by putting your chin in a machine that reads your eyes and then get there's some things to think about here. Let's make an appointment to the doctor. And the doctor then has the benefit of knowing that you do have those. And so that takes some of that early conversation out and can help to support the actual diagnosis. So that's coming. A second one that I want to share with you is a really interesting, another Canadian company. It's called Winterlight Labs. And Winterlight Labs is a tablet-based program that uses AI, and it actually analyzes your speech. Now, you may remember some of the discussions of Donald Trump and so on using speech analysis, and it's a little bit like that. So it can perform all of these types of cognitive tests very effectively. In fact, as effectively as a geriatric psychiatrist. And it can also show differences over time. And so the early diagnosis can lead to that flagging for care and can make sure that we get the help we need. We know that there are some new things happening about Alzheimer's that was flagged before, but there's no current treatments to cure. And these are the more traditional medications that you may be aware of. Again, really not incredibly effective. There is this new molecule which has received approval. There's a few other in market and still in the study process from other companies. And this is a piece of hope. So how do we get there? I'm just going to do this very fast because I want us to have some time. So when we're thinking about moving policy into action, we need to, of course, use persuasive advocacy, and many of you are key experts in that area. And so I think of advocacy as between the policy stuff that we know and the evidence and trying to get it out there in the field. And so it really sits in between government and community. And so when you're thinking about creating a policy framework like on dementia, we need to make sure that it has the solution you need. This is an example of inflatable airbag hip protectors. This was a solution nobody wanted to the very real problem of falls. So you have to have a good understanding about the key issues. And this is your snapshot for how to actually pitch something. Go in with one sentence. Hi, I'm Laura. I'm the CEO of CanAge, Canada's National Seniors Advocacy Organization. We are here to ask for 10% of the health budget, or we're here to ask for the implementation of a dementia roadmap, or we're here to ask for an awareness strategy, whatever your ask is, and then have all these other things mapped out. Finish with the ask and thank for their time and leave them with something. So if you are trying to strategize on how to work in lobby, this is the solution. Make it personal, but don't get lost in the story. And if your person that you're trying to talk to starts talking long about the story of their mother, accept that and then bring it back in. Make sure that you don't actually keep talking too much. This should really be an effective meeting where you give your information in about 5 or 6 minutes, and make sure that you are crisp in what you need to do. One of the biggest issues is going on and on about your organization, or on and on why it's a problem. The only good news about dementia is that everyone agrees with you. It's worrying. It's trying to get action that we need. So I'm hoping that the where we are, what's coming, and how do we get there was a helpful way of thinking about it. And I'll turn it back to the rest of the group.
Thank you so much, Laura. It was it's interesting just to see the comparisons of, you know, where we stand compared to other provinces, and not only with the dementia report, with other reports that you've been doing too. Just sort of that report card analysis just kind of gives you an overview about where we really need to go to get up there, you know. And I think a report card's about going into school, and everyone's kind of afraid to get that report card. So I think it's important though, because it tells you need to do something to improve it if you're getting that bad mark. So I think that's great work, and it gives people just thought to say, well, where do I, you know, where are we? I was really shocked in terms of the stats around physicians, that really not only the decrease in number of physicians versus the patients in terms of geriatricians, you know, and as you were talking about those who are maybe ready to retire and who's going to come up and replace those individuals, which creates more of a higher demand for the need. How are we going to address the need for our aging population and those specific requirements around dementia into the future? So I wonder if either one of you have ideas or thoughts around, you know, sort of bridging that gap of how do we educate, or how do we engage the physicians to be better informed, and to, you know, Laura, you're talking about being able to recognize, and I think Kathy, you talked about that as well, about, you know, knowing what the signs, so we get, you know, maybe some of this early intervention is being missed because of that lack of knowledge. Not to say that all physicians don't have some knowledge and they gain that through experience of, you know, over the years of being in practice, but is there better approaches that we can take? I don't know what your opinion is.
Maybe I'll just jump in and then turn it to Kathy. There's about 3 things that I would identify. One, it's very clear we need more than 6 hours on the entire brain in med school. And similarly, we need more than 24 minutes on mental capacity and consent. So that is outdated and has to change. There's no question. The second is we need to be able to give training right now to docs who are frankly overwhelmed, but this is one of the reasons they're overwhelmed. So I think there is a willingness to try to have effective new screening tools. And I do think that some of the technologies will really help them with that original lift. The last thing that I would say is kind of a two-parter. One, we need to give people checklists that they can go into their healthcare provider with, which is very much advanced preparation. And Alzheimer Society does a great job supporting people getting that conversation going. But the billing codes need reform, and BC just did this. Right now, there's no dementia billing code. Do you know that? Like, you can't bill for dementia. So as a result, you know, if you've got a 5-minute meeting, I mean, you can't do anything on that. You're probably renewing your prescription. So BC just changed its billing codes to allow for longer and more complex discussions. It's particularly focused on dementia. And in my view, that will help doctors be able to dig in more deeply. Kathy?
Yeah, totally agree with everything Laura said. I'd add a couple more. One is a very well-established dementia care pathway. One of the issues with family docs, in particular, being reluctant to diagnose, in addition to the reasons Laura just said, is that they actually don't know what to do if they do diagnose. So what happens next? So we need a very clear pathway for care. And then the second thing is to establish other places where people can get screened, because one of the issues as well is we don't want to overburden neurologists, geriatricians with people who don't necessarily need to be there. So can other models be developed such as Redispec, actually, which is what Laura was talking about, having optometrists start to screen. And then the Alzheimer Society doing some high-level screening to identify when people really need to go to a specialist. So those are a couple things I would add.
I'd just be interested in, and maybe people even putting in the chat if they've done any outreach in their communities to and advocating for their own community around addressing this. If people want to share that, that would be that would just kind of be helpful, just to see if people are, you know, active in their communities or have addressed this or come across barriers, maybe even posting what some of those barriers are, and maybe we could have a discussion. There was just one more other question. Before I get to that, I was just wondering too about the intergenerational piece of is there any ideas around intergenerational engagement for learning or and getting people involved, not only working like supporting, you know, it could be family members or getting into the field of working to support older adults, not only just having to be a physician, but just in general, because there seems to be, you know, that generation gap. I don't know if anybody's addressed that, or if anybody that's participating today has any engagement in that. Kathy, maybe you can start.
Yeah, I think picking up on what Laura talked about in terms of billing codes. I mean, if you can't get paid for the work that you're doing in a way that, you know, compensates you for the amount of time and effort that is needed to support people with dementia, you know, people aren't going to go into that field. So having, you know, as Laura said, billing codes modified to address so that people are actually compensated for the work that they're doing with this really important age group. I just saw a comment fly by that, you know, a doctor said, well, you know, kids are, you know, the future, old people, that's the end of life. Like, who cares? Well, that also speaks to the need to address stigma. So, you know, as we address stigma in society in general, perhaps that will also help, you know, people entering the profession in terms of doctors, social workers, etc., to know that this is a really valuable career path. These are people who have contributed to society in so many ways and actually still have so much to give and to teach all of us. And so people shouldn't shy away from that field.
And if I could build on that, and I absolutely agree, one of the ways that I often talk about dementia is just about capacity and cognitive impairment. And I will often say, when I'm talking to my students, you know, have you ever started out the evening as a mentally capable person and then had one too many tequilas or one too many whatever? Or I was a young mom, I had 3 kids in 4.5 years and I hadn't slept in, goodness knows, I don't remember how long. Everyone's had the experience of sliding up and down that capacity framework. And then when we're talking about things like powers of attorney or other planning documents, you know, really taking it away from the idea of it's only about dementia, because it's not. And when we think about dementia, we also know that our DSM criteria has taken away that name that we talk about and is now included in all kinds of different cognitive impacts. What that I think does is it allows people to understand and appreciate that mental capacity can flux and change and can be affected by many things. And so it helps to destigmatize it as well. And I think that right now, the fear basis that Kathy picked up on is so profound. Like, people can't figure out, well, what happens now? And many folks won't want to get diagnosed or have check-ins because they think that this means that their rights are going to be infringed on, that someone's going to question their ability to make financial decisions or personal care decisions. And you know what? They're right. So if you have no hope, which I want to say there is, and if you have no pathway for care, which there really isn't, and you think that getting a diagnosis may lead to questions and capacity assessments and challenges, and you lose your right to do all kinds of things, including have sex, you know, you may not want to go get diagnosed. And so we need to understand this in a rights framework and in a framework that normalizes the idea of capacity.
Yeah, thanks, Laura. That's a you know, made a lot of good points there in terms of that, you know, education, the reluctance for people to, you know, go forward and get that diagnosis. There was just one question in regards to, or maybe a comment. I have an annual test from my doctor from Toronto Memory Clinic for the last 2 years. Is this clinic capable of diagnosing various types of dementia? And I know Kathy did respond to that. And there was somebody else that asked about Baycrest having as a test site. And I know there are wait lists. Kathy, maybe talk a little bit about that based on that's kind of your area there in terms of knowing what services are available.
Yeah, Baycrest, the Toronto Memory Program are two in Toronto, really great resources. We're very lucky to have them here. The issue is, and they are more than capable of diagnosing, probably better than anywhere else, or just as well. The problem is waiting lists. You know, as Laura talked about in her comments, there just aren't enough neurologists, geriatricians, like there just aren't enough people. So even if all the people that we had, and obviously geriatricians and neurologists are more likely to be interested in diagnosing because that is their specialty, we simply just don't have enough people in those areas, and the waiting lists are long. And also, I mean, I'm coming from Toronto, so Baycrest is here, Toronto Memory Program, Sunnybrook, UHN. There are a number of centers in Toronto that are specialists in this area, but if you live in Sioux Lookout, that's not very helpful to you. So ensuring that there's equity of access across the province is also critical. And there are regions of the province that just really don't have anything. They're diagnostic deserts in terms of being able to access the type of specialists that you need.
Yeah, the geography and transportation, there's so many factors that we brought up at the very beginning of this webinar too that create some of those challenges and barriers. I do want to thank both of you. I do appreciate all the information that you've shared, the reports. I did put them in the chat box for people to access and look at, to read them through a few times, because I'm sure that you'll miss lots of that information when you read it over the first time. And reach out to either one of our speakers if you have more questions or you want to get involved somehow and you're not sure how. I know that that's Laura's organization. She's got connections within different provinces and jurisdictions that she can assist in that capacity as well. I did put up the contact information for both of our speakers, emails, phone numbers, if you're wanting to reach out to them individually. Just finally, we have a number of sessions before the holidays. The next one is next week with Dr. David Burns, who's done a lot of work around elder abuse, but they're going to be looking at ageism and the sort of that connection towards elder abuse and prevention. And there's been a lot of work being done, and he's based out of the University of Toronto, the Faculty of Social Work, and he's been quite involved, so that should be very informative, as well as he's being joined by Sheila Sheelan, who is also a consultant with us at Elder Abuse Prevention Ontario. The next day, because we like to keep busy, we're hosting another session on closing the gap, so looking at promoting health and dignity for Black older adults. And we actually have 3 doctors. Another one that's just joined this panel that will be joining us. And you can check all this out on our website under upcoming webinars. So this should be a very good session as well. Just talking about, what is the current state, similar to, we're talking about gaps in dementia, but how do we, looking at what the gaps are and what recommendations and what has been done to address the needs for Black older adults within Ontario specifically. And we have some other Francophone sessions. So if anybody is Francophone or knows anybody, we are going to be promoting those sessions as well on the following week. So again, if you have your phone or if you want to join, do the evaluation later through the link, you're more than welcome to. We do appreciate your feedback. It gives us ideas about what you want for future webinars, because we are here to meet your education needs in the community. We just passed Giving Tuesday, so I can't go without sort of asking individuals if they're interested in donating their time, join a local network, be engaged in other community organizations, the dementia work that's happening in your area, the Alzheimer Society, CanAge, I believe, is starting some chapters in different provinces. So there's so many opportunities to become engaged in giving back, and whether that's volunteer or financially, it's every action and every bit helps and goes a long way to make a big difference in protecting the rights of older adults in our communities and across our country. If anybody wants to reach out to our organization, this is my contact information. All staff are available on the website to get their contact information as well. I do appreciate everyone attending today. Thank you so much again to our speakers and our ASL interpreters. You're fabulous as always. We do appreciate you providing that support and services to our webinars. So thank you so much again, and everybody have a wonderful afternoon, and hopefully the snow stops and the sun comes out again. So thank you all, and we'll see you at our next webinar.